Clinical Judgment, Week 13. Our client is a 38-year-old female admitted with obvious respiratory distress. This client has audible high-pitched wheezing, blood pressure of 143/86, difficulty speaking, tremoring to the hands are noted. The client's chest feels very tight. The client took albuterol and beclomethasone inhaler without relief. The husband works for an asbestos removing company. The respiratory rate is 28. Heart rate is 110. Vowel sounds are active ×4. There are expiratory wheezes scattered bronchi throughout the lungs. Respiratory distress. She states, I cannot catch my breath. And her oxygen saturation is 88% on room air. I think the high-pitched wheezing and rhonchi is definitely an issue we need to look at. That can be caused by bronchial constriction or narrowed airways or partial airway obstruction, potentially asthma or some type of respiratory illness. Those elevated vital signs, again, fluid imbalance or hypoxia, decreased perfusion, or respiratory distress can cause all of those. The difficulty speaking could be from respiratory distress, hypoxia, or poor perfusion. The tremoring to her hands. Well, this could be hypoglycemia or medications. The chest feeling very tight. Bronchial constriction. Narrowed airways, partial airway obstruction. Asthmatics often complain of that when they're having an event or a respiratory illness. Her inhalers did not help. Well, it's really important for us to know what treatments were done and what the response were. Maybe it was the inappropriate medication. Maybe it was inappropriate administration. Or maybe it was the wrong dosage. Can't catch her breath. Again, bronchial constriction or narrowed airways, partial airway obstruction or asthma, and that low oxygen saturation. Again, respiratory distress, hypoxia, poor perfusion, asthma, respiratory illness. Potential complications of the wheezing could be airway obstruction. That blood pressure, CVA, aneurysm, decreased cardiac output. Difficulty speaking, well, we know that is a respiratory issue, so she just may have an inability to express what is really going on with her. Tremoring to the hands, this could be a safety risk. Her chest feels very tight. This could be caused by an MI, cardiac arrest, or a respiratory failure. Her inhalers did not help. Again, respiratory failure. Elevated respiratory rate, respiratory alkalosis or respiratory failure. Elevated heart rate, heart failure, decreased cardiac output. Those wheezes and rhonchi can be a respiratory infection or fluid volume overload, but we definitely have impaired gas exchange. Not catching her breath, impaired gas exchange, respiratory failure, respiratory alkalosis, and the low oxygen saturation, impaired gas exchange, respiratory failure, respiratory alkalosis. What is going on? Well, she could be experiencing asthma, or maybe she just has COPD. And her respiratory distress is definitely the priority here. If we don't take care of that, she could die. So we would expect there to be no respiratory difficulties. We would expect her vitals to be within normal limits and for her to have clear lung sounds. So, what are we going to do for this lady? First of all, let's look at what we might avoid. And to be perfectly honest, we need to avoid anything that is going to increase her respiratory issues, such as respiratory irritants. But what would we do? We definitely need to monitor vital signs and her lung sounds. We are going to give her bronchodilators, maybe some of the same medication, but let's try giving it through a nebulizer, which hopefully will reach deeper into her lungs. But we may also give inhalers. If this is asthma, we may give her epinephrine, definitely some oxygen, and if what we're doing is not helping, she may require mechanical ventilation. And we definitely need to provide some education to include her medication and appropriate way to administer it. What could potentially have triggered her respiratory issues? And how do we maintain appropriate respiratory status? So what would we prioritize? How about some oxygen? Probably elevating the head of the bed also. Then I would give the epinephrine and the bronchodilators. The rest of it, depending on how those work, we definitely need to monitor vital signs, lung sounds, and potentially mechanical ventilation if our interventions were not successful. Did we achieve no respiratory difficulties or vitals within normal limits or clear lung sounds? If not, what are we going to do to achieve that? Which client do we see first? Is it the client with COPD, oxygen saturation of 88, and respiratory rate of 24? Is it the client with a respiratory rate of 10, heart rate of 110, drowsiness? Is it the client with an asthma episode that receives a nebulizer of albuterol? Is it the client with pneumonia, O2 at 2, and a temp of 100.3? Well, you may say number one, but the client has COPD. These readings might be very normal for this client. So urgent, but not necessarily emergent. But look at number two. We have bradyapnea. The client has a low respiratory rate, a high heart rate, and drowsiness, which is considered a change in level of consciousness when associated with other symptoms like this. Number two is your priority client. So which parameters does the nurse monitor to ensure that a client's response to oxygen therapy gas exchange is adequate? What is this question asking? how do we monitor, or what do we monitor to determine adequate oxygenation? Would we monitor level of consciousness? Yes, because if they don't have enough oxygen, they can be confused. Would we monitor respiratory pattern? Yes. Oxygen flow rate? Yes. Pulse oximetry? Of course. The respiratory rate? Yes. Blood pressure? That's not going to tell us anything about gas exchange. So number 6 is the only incorrect answer. Now we have a home health nurse who's been caring for a client with a chronic respiratory disorder. Today the client seems confused when she's normally alert and oriented times 3. What is the priority nursing action? So remember, if I don't take care of this issue first, my client could have potentially bad or fatal consequences. So what is this question asking? Well, we need to know what causes confusion, right? Because that is the change that we are seeing. So we will base our action on that. Do we notify the provider about the mental status change? Do we check the pulse oximeter reading? Do we ask the client's family when this behavior started? Do we perform a mental status examination? Well, first of all, I'm going to check the pulse oximeter reading, and then I will notify the provider, possibly administering oxygen in the meantime. This nurse is interviewing a client to assess for risk factors related to head and neck cancer. Which questions are appropriate to include? What is the question asking? What are risk factors for head and neck cancer? Is it how many servings per day of alcohol do you typically drink? Well, we do know that excessive alcohol intake is a carcinogenic. Yes. Is it, have you had frequent episodes of acute or chronic visual problems? Well, vision in and of itself is not necessarily a cancer symptom. Is it, have you had a problem with sores in your mouth? Well, we know sores in the mouth can be a symptom of cancer and increase the risk for cancer if they are chronic. Is it, when was the last time you saw your dentist? Well, our teeth really don't have anything to do with cancer. So, no. Would it be, do you have recurrent laryngitis or frequent episodes of sore throat? Yes, we do know that hoarseness, uh, persistent hoarseness, sore throat can definitely be indications of cancer. And would it be how many packs per day do you smoke and for how many years? Yes, because tobacco, the nicotine, these are carcinogens. So which intervention does the nurse use to assist the client who suffers from chronic xerostomia secondary to past radiation treatments? If you remember from your medical terminology class, you know that xerostomia is going to be dry mouth. So what treatments would improve this? Would we offer small frequent meals to improve dry mouth? Would we suggest a moisturizing spray? Would we explain fluid restrictions? Would we teach to wash with mild soap and water? Correct answer, number 2. The nurse is taking a medical history on a new client who has come to the office for a checkup. The client states that he was supposed to take a medication called Montelukast, but that he never got the prescription filled. What is the best response by the nurse? Okay, so we know we're looking for a response by the nurse, but what is this question really asking? Well, we really kind of need to know what is going to happen if the client does not take this medication. But it could be, is there a reason why the client has not gotten the medication? So, would the response be, when were you first diagnosed with a respiratory disorder? Would the response be, why didn't you get the prescription filled? Would the response be, tell me how you feel about your decision not to fill the prescription? Would the response be, are you having any problems with your asthma? Well, number 2 and number 4 both kind of answer the questions that we had. But let's look at the question again. It asks, what is the best response? So which response is going to provide us the most information, the most pertinent information? And that would be number 4, because we know Montelukast is administered with asthma. We need to know if not taking the prescribed medication is causing them to have increased problems with the asthma. Then we can address why the prescription was not filled. Last question. Which statement by a client indicates correct understanding of drug therapy for rhinosinusitis? What is this question asking? Well, we're talking about drug therapy for rhinosinusitis, so what drugs are appropriate? And what effect would those drugs have? Is it a side effect of my antihistamine drug can be increased itching? Is it when I am feeling better, I can stop taking my antibiotics? Is it I will take 2 acetaminophen tablets every 4 hours to prevent fever? Is it my decongestant will decrease the swelling so I can breathe better? Well, rhinosinusitis may be an antihistamine. It does not increase itching, it should decrease itching. So number 1 is incorrect. Well, we know that it's not going to be an antibiotic for rhinosinusitis. They have the nasal congestion, the runny eyes, so may have a runny nose. So not necessarily a fever, but it will involve a decongestant to decrease the swelling so the client can breathe better. Correct answer, number 4.